Imagine stepping into a clinic for a medical treatment, and it works. Like, it works incredibly well.
Right, which is usually the goal.
Exactly. Usually the goal of any medical intervention is just restoration. You fix a broken connection, you heal a tear, and you just get your body back to a baseline of normal, comfortable function.
Yeah, you just want to feel normal again.
Right. But today, we are asking a very particular, honestly almost sci-fi sounding question about regenerative medicine.
It really is fascinating.
It is, because when a procedure is explicitly designed to regenerate nerve endings and, physically increase human sexual sensation, what happens when it overshoots the mark?
That's the big question.
Right, like, can a treatment actually cause the body to feel too much? Can this quest for heightened sensation lead to just an overwhelming hypersensitivity?
Yeah, it really forces us to confront how unpredictable the human nervous system can be, especially when we start, manually triggering its healing mechanisms. We're entering an era where we can actively manipulate the biological architecture of our own senses. And that comes with some fascinating and, frankly, sometimes shocking side effects.
And that is exactly the core mission for today's deep dive. We are unpacking a stack of medical literature, clinical abstracts, and patient information leaflets to look at a highly specific regenerative procedure known as the O-shot.
Also known as PRP therapy.
Yes, platelet-rich plasma. And this involves taking that PRP and injecting it directly into the genital area.
Which sounds intense, I know.
It does. So we're going to explore what actually happens down on the pelvic floor when you introduce this serum. We'll look at how it physically alters cellular tissue to treat everything from severe urinary incontinence to sexual dysfunction.
Right.
And ultimately, whether rewiring your nervous system carries the risk of dialing that sensitivity up to an agonizing level.
And for you listening, this is a topic worth exploring, regardless of whether you have any medical background.
Oh, absolutely.
You might have heard of PRP being used in sports medicine, right? Like to heal a torn rotator cuff. Or even in dermatology for things like the vampire facial.
Right, the vampire facial is huge online.
Exactly. But its application in gynecology is this rapidly emerging frontier. We're observing clinicians using a patient's own biological material to reverse tissue degradation, and they're doing it in ways that synthetic medications simply cannot achieve.
Okay, so before we talk about hypersensitive nerves and, electric shocks in the pelvis,
Let's back up a bit.
yeah, we need to understand what is actually inside the syringe. What are the biological mechanics of this liquid gold? Like, if I walk into a clinic for this procedure, what is the very first thing that happens?
So the raw materials come entirely from your own body.
Okay.
The procedure starts with just a standard blood draw. The clinician takes a relatively small amount of blood from your arm, usually around 15 cubic centimeters.
Not a ton.
No, not at all. And that vial of whole blood is then placed into a specialized centrifuge.
Okay, and a centrifuge is basically just a high-speed spinner, right?
Yeah, exactly.
It uses centrifugal force to separate the blood components based on, their physical density.
Right. So the spinning process stratifies the blood into 3 distinct layers. The heavy red and white blood cells, they get forced down to the very bottom of the tube.
Makes sense.
Then the lightest material, which is this watery fluid called platelet-poor plasma, rises to the top. But the target is the thin middle layer separating the two.
Ah, the liquid gold.
Exactly. That is the platelet-rich plasma. By isolating that specific layer, the clinician extracts a concentrated serum that has roughly 4 times the normal concentration of platelets found in circulating blood.
Wow, 4 times. Because I think a lot of people operate under the misconception that platelets are just the body's spackle.
Right, just for scabs.
Yeah. We learned in grade school that when you get a paper cut, platelets clump together to form a scab and stop the bleeding. But they're doing a lot more than just plug in holes, aren't they?
Oh, far more. Platelets are essentially delivery vehicles for highly potent signaling molecules. They're packed with these things called alpha granules, which contain concentrated growth factors.
Growth factors like what?
We're talking about molecules like vascular endothelial growth factor, or VEGF, and platelet-derived growth factor.
Okay.
When these molecules are released into tissue, they don't just patch a leak. They act as, cellular foremen on a construction site.
I love that analogy.
Yeah, they stimulate angiogenesis, which is the biological process of growing brand new blood vessels from pre-existing ones. They command local cells to ramp up collagen synthesis. And crucially for our focus today, they actively stimulate nerve regeneration.
Okay, so the centrifuge process is basically like making an espresso concentrate out of your body's own healing properties.
That's a great way to put it.
We pull out the most active, potent ingredients and just leave the rest behind. But if you take this espresso concentrate of platelets and inject it back into the body, do they automatically start building new blood vessels? Or do they need to be, like, instructed to start working?
They need to be instructed. Platelets actually circulate through your veins in a dormant resting state.
Oh, interesting.
Yeah, they have to be activated to release those growth factors. In the context of an injection, activation happens upon exposure to tissue collagen.
Okay, so the tissue itself turns them on.
Right. When the needle introduces the platelets into the extracellular matrix of the target tissue, the collagen acts as a key, unlocking the platelets. And some clinicians will also mix in a liquid activator, like calcium chloride or thrombin, right before the injection.
Just to make sure they all fire at once.
Exactly. To ensure an immediate explosive release of those growth factors.
So the moment those factors are released, what is actually happening in the tissue? I mean, does it just heal instantly?
Not instantly, no. The release triggers a highly orchestrated, 3-phase healing cascade.
Okay, phase 1.
Phase 1 is the inflammatory phase. That generally lasts from the day of the injection through day 4. The body recognizes the growth factors, assumes there's an injury that needs managing, and just floods the area with macrophages to clear away cellular debris.
Which means the patient is likely going to feel soreness, swelling, and heat in that area, right?
Absolutely. The tissue is aggressively prepping the site.
Got it.
Then phase 2 is proliferation, stretching from roughly day 5 to day 21. The local cells go into overdrive. They begin laying down new granulation tissue.
Let's define that for a second. Granulation tissue is that bumpy, pinkish tissue you sometimes see forming over a deep scrape when it's healing, right?
Yeah, that is a perfect visualization. It's essentially the biological scaffolding. It's very rich in new, fragile blood vessels and connective tissue.
Okay, and phase 3.
Finally, phase 3 is tissue remodeling. This takes weeks, and sometimes even months. Yeah. The messy scaffolding of new collagen fibers is slowly reorganized, cross-linked, and aligned, which structurally thickens and strengthens the entire area.
Okay, so if these growth factors are acting as this specialized construction crew that builds new blood vessels and collagen, how did we get from treating a damaged knee tendon to injecting this into the pelvic floor?
It seems like a leap, right?
Yeah. What was the logical leap there?
Well, the underlying mechanism of tissue degradation is remarkably similar across the entire body.
Really?
Yeah. If a torn tendon is failing to heal because it lacks adequate blood flow and structural collagen, the exact same principle applies to vaginal and clitoral tissue that is thinning, painful, or losing sensation due to a lack of vascularity.
That makes total sense. And the clinical applications detailed in our sources are incredibly specific about how this is done.
Very specific.
When we talk about the O-shot, the anatomical targeting is not random at all. The procedure involves a strong local anesthetic, and then the concentrated PRP is injected into the anterior vaginal wall, which is commonly referred to as the G-spot area. All right.
And then directly into the clitoris itself.
Yeah, the technique requires extreme precision. Clinicians typically inject the PRP into the clitoral area using a clock phase pattern.
Like around the edges.
Exactly. Often at the 12, 3, 6, and 9 o'clock positions. The goal is to create a ring of PRP blebs.
Wait, what exactly is a bleb? That's a funny word.
It is. A bleb is a small superficial pocket of fluid underneath the skin, very much like a tiny blister.
Okay, I can picture that.
So by creating a ring of these PRP blebs around the clitoris, the clinician ensures that the growth factors thoroughly saturate the underlying structures, specifically the bilateral crura and the glands.
And for those trying to picture the anatomy, the bilateral crura are essentially the legs or the wishbone-shaped roots of the clitoris that extend deeply inside the body.
Right, exactly.
They're the primary structures that engorge with blood during sexual arousal. So who is the typical patient walking into a clinic for this? Because the patient profiles in the clinical abstracts range wildly. They really do. A very significant demographic consists of postmenopausal women suffering from genitourinary syndrome of menopause, or GSM.
What does that entail?
Well, as systemic estrogen levels drop naturally with age, the vaginal and vulvar tissues undergo severe atrophy. They thin out, they lose their natural elasticity, and the local blood vessels retract.
That sounds incredibly painful.
It is. It causes intense dryness, micro-tearing, and chronic pain.
The sources also feature a substantial number of breast cancer survivors.
Yes, that's a huge group.
Many of these patients are prescribed aromatase inhibitors, which are medications designed to deliberately suppress the body's estrogen production to prevent the cancer from recurring.
Exactly.
But a side effect of that life-saving medication is that it plunges the patient into severe medically induced menopause. And because of their cancer history, they cannot safely take topical estrogen creams to fix the vaginal atrophy.
Right, hormone replacement is off the table, so PRP becomes a vital, non-hormonal alternative to actually restore their tissue.
That's incredible.
And we also see a high volume of patients diagnosed with female sexual dysfunction, or FSD. This is characterized by a persistent, distressing drop in desire, arousal, or the physical ability to achieve orgasm.
And what does the data say there?
The clinical data on PRP for this demographic is striking. In one of the highlighted studies, researchers evaluated patients using the standardized female sexual function index. Prior to the procedure, the average total score was 16.5.
Okay.
Following the PRP treatments, those average scores jumped to 28.5.
Wow. A 12-point leap on a standardized medical index is massive.
It's huge.
The researchers noted huge statistical spikes specifically in the domains measuring desire, arousal, and orgasm. But I do have to play the skeptic for a moment here.
Go for it.
If you look at social media, there are hundreds of influencers talking about getting these procedures alongside lip fillers and Botox.
Oh, absolutely.
One of our sources even notes that 78% of women seeking aesthetic gynecology got their primary information from the media.
That's a real statistic, yeah.
So, is there a danger that this is just a cosmetic fad? So-called genital beautification masquerading as a medical breakthrough?
The cosmetic marketing surrounding the procedure is aggressive and undeniable. It is frequently bundled with aesthetic treatments.
Right.
However, dismissing it as a purely cosmetic fad ignores the profound medical realities it's addressing for patients with severe pathologies.
You're talking about conditions where aesthetics are the absolute last thing on the patient's mind.
Exactly. Consider a condition like vulvar lichen sclerosis, or VLS. This is an intractable, chronic autoimmune condition of the skin.
I read about this. It's brutal.
It causes intense inflammation, progressive tissue atrophy, and thick white scarring. Left untreated, the disease progression is devastating. The labial tissues can literally fuse together, burying the clitoris and forming rigid strictures.
A stricture meaning the tissue has scarred so heavily that the vaginal opening actually narrows and loses its ability to stretch.
Yes.
The physical pain of that sounds unimaginable.
The psychological toll of suffering in silence with a condition like VLS is enormous. Yet, the clinical data reveals that when PRP is injected into these scarred areas, often combined with a physical procedure like dermabrasion to break up the scar tissue, it genuinely restores tissue integrity.
It actually reverses the scarring.
The flood of growth factors halts the degenerative scarring process and prompts the tissue to rebuild healthy, flexible collagen. It significantly reduces patients' scores on the female sexual distress scale. So this is about restoring fundamental quality of life, not aesthetics.
Okay, so let's follow that biological process to its logical extreme, because this brings us back to the core question of this deep dive.
Right, the sensitivity issue.
We have established that this espresso shot of growth factors successfully commands the body to grow new blood vessels and new nerve endings to heal damaged tissue.
Yes.
But you are deliberately stimulating nerve growth in the clitoris, which is already the most nerve-dense region of the entire human anatomy.
It is.
Doesn't that risk overloading the hardware? Like, can the O-shot cause excessive, painful sensitivity?
The short answer, drawn directly from the ACE Group Patient Information Leaflet and Clinical Adverse Event Reports, is yes.
Wow. Okay.
Excessive sensitivity is a documented, recognized risk of the procedure.
How often does it happen, and why? Is it just the trauma of being poked with a needle in a highly vascular area?
The mechanical trauma of the needle is certainly a factor. Anytime a sharp object is introduced into a nerve-dense area, there's a risk of grazing or injuring a nerve bundle.
Sure, that makes sense.
But the more complex reason lies in the chaotic nature of biological nerve regeneration. Nerves do not simply grow back in clean, orderly lines.
I was reading about this in the abstracts. When a nerve is repairing itself, or when new nerve endings are stimulated to grow by something like VEGF, they sprout, right?
Yes. Sprouting.
They send out these tiny microscopic shoots trying to find a connection, almost like a frayed electrical wire looking for a terminal.
Exactly. And those developing nerve sprouts are highly unstable and incredibly hyperexcitable. They misfire frequently.
Oh, wow.
The medical literature describes this manifesting in a few ways. Some patients experience localized numbness. Others experience neuralgia, which patients describe as a sudden, sharp, electric shock-type pain shooting through the pelvis.
That sounds awful.
And many experience outright hypersensitivity where altered, amplified sensations just become overwhelming.
It sounds like turning the volume dial on a stereo up so high that the music heavily distorts.
That's a perfect way to describe it.
Like the signal becomes so strong that it stops being pleasant music and becomes
Mhm.
physically painful to listen to. A gentle touch suddenly registers to the brain as a blaring, uncomfortable alarm.
The volume dial analogy captures the patient experience perfectly. The sensory input mechanism is temporarily broken. The threshold for what the brain perceives as too much is drastically lowered by those misfiring nerve sprouts.
I mean, honestly, if I am a patient reading a medical leaflet that tells me I might experience random electric shocks and agonizing sensitivity in my pelvic floor, I am immediately canceling my appointment. That sounds terrifying.
I completely understand that. It is deeply distressing for a patient to experience, which makes clinical context essential here.
Right.
The medical literature provides strong reassurance. This painful hypersensitivity is almost always a temporary byproduct of the first two phases of the healing cascade we discussed earlier.
Oh, the inflammatory phase and the proliferation phase.
Exactly. During those first few weeks, the tissue is swollen, local inflammatory markers are high, and the new nerve pathways are actively and aggressively sprouting. The nerves are essentially angry while they're under construction.
The scaffolding is up, the workers are making a mess, and the electrical signals are crossing.
That's it, exactly. But once the body shifts into phase 3 tissue remodeling, the chaos settles.
Okay.
The new nerve fibers mature, establish proper connections, and the inflammatory markers dissipate. The sources are clear that while this distorted volume can last for a few turbulent weeks, permanent nerve damage or permanent, unresolvable hypersensitivity from a PRP injection is exceedingly rare.
Okay, so the nervous system generally recalibrates the volume dial back to a functional, enhanced state.
Yes, it finds its new baseline.
All right, let's assume a patient understands the risk of temporary hypersensitivity and decides to move forward. The clinical sources detail another major application for this procedure that has literally nothing to do with sexual sensation.
Right, the incontinence treatments.
Doctors are using pelvic PRP to treat stress urinary incontinence, or SUI. And I have to admit, the mechanics of this completely confuse me.
It seems counterintuitive at first. So SUI is the involuntary leakage of urine that happens when abdominal pressure increases, like when a person coughs, laughs, sneezes, or lifts something heavy. It is incredibly common, usually resulting from the pelvic floor muscles and the tissue supporting the urethra weakening over time due to childbirth, chronic strain, or aging.
But if the issue is that the pelvic floor is structurally weak and the urethra can't stay squeezed shut, how does injecting a watery plasma fix a mechanical leak? Doesn't the fluid just disperse into the tissue and squish out of the way when the person coughs?
If the fluid just sat there, it wouldn't help at all. But remember, the cellular commands PRP issues.
The foreman on the construction site.
Exactly. For incontinence, the clinician injects the serum not into the clitoris, but directly into the tissue surrounding the external urethral sphincter.
Wow.
The growth factors trigger massive local collagen synthesis. Over the following weeks, the tissue physically thickens, it bulks up, becoming denser and firmer.
So the body is manufacturing its own biological caulk to tighten the seal around the urethra.
That's brilliant, yes. That new, dense collagen creates renewed physical resistance against the urethra, keeping it closed during moments of strain.
That's wild.
And the clinical measurements are fascinating. Researchers use a metric called a 1-hour pad test to evaluate SUI. A patient wears an absorbent pad, drinks a specific amount of water, and performs a series of physical exercises.
To intentionally try and trigger a leak.
Yes. The pad is weighed before and after to measure the exact gram weight of the leakage.
Okay, so what did the numbers show after the PRP treatments?
In one of the non-randomized clinical studies highlighted in our stack, the average pad weight before treatment indicated 34 grams of urinary leakage.
Yeah.
After the PRP remodeling phase was complete, the average weight dropped to just 2 grams.
Just 2 grams. That is the difference between needing to wear protective garments every day and just living a normal life.
It's life-changing for these patients.
It's functioning as a non-surgical alternative to having a synthetic mesh implanted in the pelvis or undergoing ablative laser therapies to scar the tissue tight.
Exactly.
Let's look at the actual recovery process, though, because whether a patient is getting this to stop incontinence or to treat sexual dysfunction, the rulebook for aftercare is very rigid.
Very rigid. The post-procedure instructions dictate several non-negotiable rules. One of the most prominent is that patients are instructed to abstain from sexual intercourse for at least 24 hours following the procedure.
From a purely mechanical standpoint, that makes total sense. I mean, the clinician has just made multiple needle punctures in a very delicate, bacteria-rich environment.
Right.
Those physical injection sites need 24 hours to properly clot and seal to prevent foreign bacteria from being introduced into the deep tissue and causing an infection.
Infection control is definitely the primary driver there. But there's another major recovery rule in the patient leaflets that reveals a fascinating quirk of human biology:
I saw this in the literature, and it completely stopped me in my tracks.
the painkiller rule.
Yes. Patients are specifically told to avoid ibuprofen, aspirin, naproxen, and any other NSAIDs for a week prior to the procedure and for several weeks after.
Yeah.
If I just got multiple injections in an incredibly sensitive area and my nerves are sprouting and causing swelling, my first instinct is to reach for a bottle of ibuprofen.
Of course it is.
Why would a clinician ban a basic over-the-counter painkiller?
This is a critical concept in regenerative medicine. Medications like ibuprofen are NSAIDs, which stands for non-steroidal anti-inflammatory drugs.
Yeah.
Their entire pharmacological purpose is to interrupt the body's inflammatory response. But let's rewind to the 3 phases of PRP healing.
Phase 1 is inflammation.
Right. NSAIDs work by chemically blocking the pathways that cause inflammation. If you introduce an NSAID into your system while you have concentrated platelets trying to work, the medication effectively paralyzes the platelets.
Wait, really?
Yes. It chemically deactivates their ability to release those crucial growth factors.
Oh my God, so if you take a pill to reduce the swelling, you are actively turning off the exact biological mechanism you just paid a doctor to trigger.
Exactly.
You're shutting down the construction site before the foreman can even hand out the blueprints.
The swelling and the inflammation are not negative side effects of the procedure. The inflammation is the required catalyst. You need the tissue to become inflamed so the local cells know it's time to rebuild.
That completely inverts how we are conditioned to handle medical recovery. We are so used to immediately suppressing any pain or swelling with a pill, we forget that swelling is the body's engine turning on.
It's true.
If a patient doesn't understand the why behind that rule, they could easily sabotage a highly advanced, expensive regenerative procedure just to get rid of a mild ache.
It really highlights why patient education is just as important as the clinical technique itself. When we rely on the body's autonomous systems, we have to let them run their course, even when it's uncomfortable.
Wow. Let's zoom out and look at the big picture of what we've explored today. We have tracked how drawing a simple vial of your own blood, separating it in a centrifuge to isolate a concentrated serum of platelets, and re-injecting it can initiate some staggering biological changes.
Truly staggering.
We've seen how it can command the body to build biological caulk to stop stress urinary incontinence. We've seen how it can halt the severe scarring of autoimmune conditions like VLS. And we've seen how growing new blood vessels and nerve endings can revitalize sexual function. But we've also unpacked the chaotic reality that rewiring a nervous system can sometimes trigger a temporary shocking spike in sensitivity while those fragile nerve sprouts try to find their connections.
It's a powerful tool, but it's not without its turbulence.
Exactly. For you listening, whether you're actively researching regenerative therapies for a specific medical condition or you're simply fascinated by the cellular biohacking of the human body, understanding these granular microscopic mechanics is just eye-opening.
It really is.
Seeing how our tissue orchestrates its own healing gives us a profound new appreciation for the complex biological machinery we walk around with every day.
And it leaves us with a rather profound concept to mull over as this technology advances.
What's that?
Well, if we are now entering an era where we can literally isolate our own bodily fluids, process them, and re-inject them to fundamentally dial up our sensory experiences, are we approaching a future where human physical sensation is no longer a fixed genetic trait, but an adjustable setting?
Oh.
Right. And if we can eventually learn to perfectly tune our ability to feel, how will that change our baseline definition of what is natural?